This chapter will discuss the microsurgical management of intracranial occlusion disease, specifically the role of ECIC bypass in the management of stroke. Bypass for stroke. Perhaps this can be summarized best as a beautiful and elegant operation seeking a disease to treat. No area of neurosurgery has been so studied and fraught with bias, preconceived opinions, leading to ultimate frustration. Despite significant expense, efforts, and multiple studies, the role of bypass in the treatment of stroke and preventing stroke remains elusive. The original ECIC bypass trial failed to show benefit of bypass in preventing stroke. This shocked the neurosurgical community at the time. Subsequent studies were performed with mixed results. The most recent randomized controlled trial, the COST trial, also showed no benefit. This prompted this hasty quote that we should close the door on bypass forever. Before we do such, I think it important to look at the specific failures and shortcomings of these trials. Let us start with the history. Originally, Connolly performed the first bypass of a cervical carotid artery in 1953. This was for tumor surgery, but the seed had been planted, and subsequently Dr. Gill in 1969, while working in Vermont, performed the first STA to MCA bypass after having worked out the details in various dog experiments. Lougheed performed the first saphenous bypass for a CC to ICA in 1971. Subsequent refinements led to this procedure becoming part of the standard neurosurgical armamentarium. STA-MCA bypass flourished until its peak in 1985 and the publication of the ECIC bypass trial. The ECIC bypass trial was much anticipated. It was the first major study of a cerebrovascular procedure in the modern era. It was initiated in 1977 by Dr. Barnett and several colleagues. The intention was to show that bypass surgery for stroke among patients with atherosclerotic ICA and MCA lesions would benefit and prevent stroke. Unfortunately, the conclusion revealed that surgery provided no benefit in the protection against stroke. This was a shock to the community and a controversial conclusion which had a dramatic impact on the use of this procedure in North America. The initial study design included 71 centers in the United States, Canada, Japan, and Europe. At the end of the trial, 1,377 patients were randomized with anterior circulation strokes, retinal infarction, or TIAs within 3 months of presentation. 633 patients were randomized to surgery, while 714 received best medical therapy. The lesions were somewhat heterogeneous, leading to one of the pitfalls with this study. It included MCA stenosis, MCA occlusion, ICA stenosis, or occlusion. The planned follow-up was 5 years, and the primary endpoint was fatal or non-fatal stroke in all vascular territories. At a mean follow-up of 56 months, the ECIC bypass study provided no significant protection against stroke. There was an 18 versus 20% stroke rate when comparing best medical therapy versus the bypass group. This shocked the community, and various subgroup analyses were asked for, but again failed to show a benefit. The technical results were actually quite good. There was a 96% patency, a 4.5% perioperative major stroke or death. However, 33% were included prior to surgery as part of the intent to treat analysis, muddying the waters to some degree. there was a 1.3% stroke rate in the non-surgical arm. Of note, when they looked at the subgroups, including the MCA stenosis and MCA occlusion group, the outcomes were actually worse. The results of this trial were presented at neurosurgical meetings and were a shock to the neurosurgical community. Dr. Skip Peerless at the time presented the summary of the talk with a one slide containing the word none. Basically, controversy arose from these results. There were multiple series published with clinical improvement. There had been various studies showing post-bypass cerebral blood flow was significantly improved. Bypass patency remained high over time. However, despite this, given the randomized aspect of the ECIC bypass, it had a significant impact on clinical practice in North America. Government and third-party agencies withdrew funding, payments stopped for the procedure, and surgeons still performing the procedure were subject to malpractice liability. This trial also initiated an intense scrutiny of cerebrovascular surgery and led to the subsequent endarterectomy trials. The controversy basically arose from many published reports demonstrating benefit in smaller, uncontrolled groups of patients. The results of the ECIC bypass were in direct conflict with clinical impression of many well-qualified observers and experts on the field. The results were also contrary to what the accepted theoretical knowledge was at the day. Critics of the study began to voice their opinions, in particular given the impact on their practices. Several issues came to light. Centers contributing 2 to 4 cases per year achieved bypass patency rate equal to that of large volume centers. This raised questions regarding the integrity of the data, given the technical challenges required by this procedure. There was a significant number of asymptomatic patients enrolled. These and other concerns were aired at the 1986 AANS meeting, and it prompted Thor Sunt to initiate an immediate phone survey of participating centers. The results of these surveys and scrutiny led to the following findings. 57 of the 71 centers randomizing 601 total patients. However, there were 2,572 patients who received surgery outside the study during the study period. This introduced a significant selection bias. Basically, physicians were so convinced of the benefit of this procedure that they did not want their patients randomized. The study publication reported only 115 eligible patients had refused entry and 52 whose physicians insisted on surgery outside the study protocol. Clearly, this was in conflict with the findings. The committee, convened by Robert Ogeman, Thomas Langford, Nicholas Zervis, and Sidney Goldberg, looked further into these issues. After an extensive investigation, the committee presented its conclusions. In the end, the trial showed no benefit. There were a large number of eligible patients treated outside the trial, and only limited data was available on those, preventing any real analysis. Conclusion that the ECIC bypass is never indicated was felt to be too sweeping, given that the study suffered from significant bias, and the patient assessment methods at the time were dated and inadequate. In summary, the ECIC bypass trial failed to show benefit. However, the ratio of symptomatic versus asymptomatic patients was low. Less than 1 symptomatic patient per center per year was enrolled. Over 2,500 patients underwent surgery outside the study, introducing a significant bias. There was insufficient power in the subgroup analysis, and at the time there was no angiographic criteria for entry. There was no requirement for CT or angiography in the preoperative interval. At the time there was no cerebrovascular hemodynamic criteria and no criteria to stratify the subgroup of stenosis. The aftermath was devastating. Few bypass procedures were performed. New graduates and trainees no longer learned this procedure, and it became a small niche amongst certain cerebrovascular surgeons. What remained was bypass for flow replacement in situations of tumor resection, unclippable aneurysms, or acute dissections, and the persistent flow augmentation role for cerebral hypoperfusion syndromes and moyamoya disease. We will focus on the patients with hypoperfusion. This was a common finding in patients with TIA. Mead found 50% incidence of complete occlusion of carotid arteries in 380 patients presenting with TIA. Symptomatic patients were felt to be at high risk for stroke. The estimated annual risk was somewhere between 5 and 7% for any stroke and 2 to 6% for ipsilateral stroke. Various hemodynamic investigations further refined the science on this patient subgroup. It was found that a decrease in cerebral perfusion pressure led to autoregulatory vasodilation of the affected vascular bed. Increased fraction of oxygen extraction was also noted. Various tests have been used to confirm these hemodynamic impairments and potentially identify a subgroup of patients with carotid occlusion that may benefit from a bypass procedure. The clinical syndrome associated with these patients includes various manifestations suggestive of hemodynamic impairment, specifically orthostatic TIAs, limb-shaking TIAs, a finding of linear white matter infarction in the centrum seminal valley near the watershed regions, as well as the possibility of cognitive decline, which has received increasing attention in recent years. These hemodynamic findings and the rigorous scientific evaluation of these patients resulted in a resurgence of interest in the bypass for stroke. Grubb published in 1998 in the journal JAMA a finding that increased oxygen extraction fraction as measured by PET distal to a symptomatic carotid occlusion was an independent risk factor for stroke. Basically, a prospective blinded longitudinal cohort was evaluated. They had 81 patients with a mean follow-up of 31.5 months. The endpoint was any ipsilateral stroke or death. They found that increased OEF was associated with an increased risk of stroke at a very significant level. The relative risk was 6 for all stroke and 7.3 for ipsilateral stroke. With the publication by Grubb's paper from his group, it was felt that the bypass procedure may still have life. The agreement was that patients with symptomatic carotid occlusion and evidence of hemodynamic insufficiency that were refractory to medical therapy may benefit from bypass procedures. This led to the COS trial. This trial sought to correct some of the deficiencies of the original ECIC bypass trial. It was initiated as an attempt at a more scientifically rigorous study identifying the subgroup of patients most at risk. It required modern physiologic imaging, specifically oxygen extraction fraction as measured by PET, and it required confirmation of surgical results, expertise via certification. The study design included 2 parallel groups that were going to be evaluated prospectively in a 1-to-1 randomized open-label blinded adjudication treatment trial. Basically, the hypothesis was that STA to MCA anastomosis, when combined with medical therapy, could reduce by 40% the subsequent occurrence of an ipsilateral stroke in patients who had symptomatic ICA occlusion and evidence of increased OEF as measured by PET. The primary endpoints were all stroke and death within the first 30 days and ipsilateral hemispheric ischemic strokes within 2 years. They also included the intent to treat analysis. The much anticipated results led again to disappointment. 195 patients were randomized between June 2002 and June of 2010. 97 were in the surgical group, 98 in the non-surgical group. The only difference between groups was a systolic blood pressure baseline, and 99% follow-up was completed. What was found was that the 30-day stroke rate for the surgical group was approximately 14.4% versus 2% in the non-surgical group. An intent to treat analysis at 2 years, 21% stroke rate for the surgical group, 22.7% stroke rate for the medical group. The 14.4% stroke rate had ipsilateral ischemic infarcts within 30 days. Bypass patency was actually quite high at 98% at 30 days and 96% at last follow-up, not dissimilar from the original ECIC bypass trial. Basically, what was found was that STA to MCA bypass markedly improved OEF level, but did not normalize it. But despite this, the stroke rate was still significant. The study was terminated after a futility boundary was crossed. Looking at the Kaplan-Meier curves, one sees that the original morbidity and mortality for the surgical group, as expected, would be within the first few days and recovery. Subsequently, it levels off. The medical group continued to just increase gradually over time. The question remains, had the study not been terminated, would the curves cross, eventually showing benefit for the surgical group? Subsequent controversy resulted in looking into some of the details. And one such detail came up was that the occlusion time during the procedure was significantly higher than most expert cerebrovascular surgeons would note in their procedures. The question of technical capability of the surgeons within the study was raised. Due to the low enrollment, there was pressure from funding sources regarding the completion of the study. This allowed opening up the original stringent criteria for inclusion as a surgeon in the study to less so, raising the question of technical competency. Despite the controversy, the disagreements, and much discussion, in conclusion, the study showed that bypass failed to provide overall benefit on 2-year stroke recurrence. 30-day mortality and morbidity was higher than expected at 15%. What was interesting was that the medical natural history was significantly better than had been predicted based on previous medical studies. Despite a decrease in the 2-year stroke rate for surgical patients of 6% versus 12% projected, medical patients only had a 23% stroke rate, much lower than the projected 40%. As with all studies, the retrospective look always leads to identifying areas of critique and shortcomings. For the cost trial, the significantly lower stroke rate observed for the medical arm still remains elusive. The discord regarding the PET methodology employed and its applicability has also been raised. In order to improve the original recruitment, the stringent surgeon experience criteria were loosened. Average occlusion times of 45 to 50 minutes seen in the cost trial are quite high compared to the 25-minute average among those who perform the procedure commonly. It also appears that there was a stable subset of patients that were randomized into the trial. This is evident by the average time from randomization to surgery being 72 days. One must question whether a patient who received surgery 72 days later really required the procedure at all. Single TIA patients could be recruited, another possible subgroup that did not require the procedure at all, and the need and ability to travel for the PET study, which was a requirement, also complicated the recruitment. In the end, the main issue remains. The study did not address the symptomatically acute patient with unstable postural symptoms or recurrent limb shaking TIAs, or those with increasing incidence of TIAs. These patients were specifically excluded. Exclusion criteria from the COS specifically stated acute, progressing, or unstable neurological deficit would not be included. Hence, the question of bypass in this most common group remains unclear. Another issue is the role of revascularization and neurocognition. There has been increasing data over the past few years suggesting that cerebrovascular improvement may impact cognition. Unfortunately, the RECON trial also did not show significant improvement in cognitive function. Yet despite this, other studies have shown improvement in neurovascular function and cognitive function after bypass. There have been physiologic studies showing improved motor plasticity, as well as the fact that reperfusion normalizes motor activation patterns in large vessel disease. The questions remain unanswered and beg for more investigation. In conclusion, despite multiple studies and investigations, the bypass procedure remains in a nebulous state. It has failed to show benefit in preventing stroke, but the studies had their issues. Surgeons still continue to perform the procedure in this small subgroup of acute patients, and there is also increasing study looking at cognitive function with bypass. The questions remain unclear, and further studies are being planned for the future, including registries looking at the risks of the procedure, improved cerebral blood flow, and cognition.